2, 1, and go.
Good evening, everybody. We are having our live session probably after 10 days, I think, last 10 days back we had. We are discussing on next swelling, how to examine. It's very important for students. We have got with us Professor G. Muthukumaran Sir from Savita Medical College. Welcome you, sir, very much. We have got with us Professor Robinson from Tiruvalla. Robin, my good friend, very academician and a good surgeon also. Robin, I welcome you. We are missing you last time. Thank you very much. We got with us my dear friend Dr. Keshav Prasad surgery from Surya Medical College, KVG. A good surgeon, laparoscopy surgeon and academician. Keshav, welcome you. We have got Professor Manoharan Sir. He joins. Sir joined, I think. Sir, good evening, sir. We have got Manoharan Sir with us from Manakula Vinayak Medical College, Puducherry. Thank you very much for joining. I know you are busy today. You have got some specific commitments. In spite of that, you have joined. Made me very elated. I warmly welcome you, sir. And of course, today's presenters are Isha and Abhay Mohan from Kasturba Medical College, Mangalore, my college. Yes, they're in my unit currently. They're presenting the next swelling. I welcome you both. Sir, Manoharan Sir.
Good evening, sir. Good evening, sir.
Good evening, sir.
Good evening, Dr. Robin.
Robin is there with us, sir.
Good evening, Robin. Good evening, Muthukumar.
Namaskar, sir. Namaskar.
Good evening, Keshav, sir. Namaste.
Namaste, sir.
Sir, we'll straight away start with the presentation, I think, no, sir?
Yes, sir.
Yes.
Isha, you are presenting history?
Yes, sir.
Okay, present.
Okay, so I would like to a very warm welcome to one and all present here. So I would like to begin by thanking all the professors who have joined today for taking out your time to help us out with this case presentation, which will help us in our future clinical acumen. And I would also like to thank the audience for listening to it, and we hope they find it informative and helpful. So, beginning with the case presentation, we have Mr. X, who is a 77-year-old male agriculturist by profession and who presented to Government Venlock Hospital with chief complaints of, can you please change the slide? Swelling on both sides of the neck for the past 6 months and hoarseness of the voice for the past 3 weeks. Moving on to the history of presenting illness. Can you change the slide? Patient was apparently asymptomatic 6 months ago when he noticed the swelling on both sides of the neck. It was insidious in onset and gradually progressive in nature. The swelling was initially small, painless, and measured approximately 2 into 2 centimeter and has now progressed to its current size. He later developed hoarseness of voice 3 weeks back, which was gradual in onset, progressive, and persistent in nature. Moving on to the negative history, we have no symptoms of suggestive of hypo or hyperthyroidism. There is no history of throat pain or episodic voice loss. There is no history of dysphagia. There is no history of dyspnea, cough, or hemoptysis. There is no history of fever, weight loss, or night sweats. There is no history of trauma. Also, there is no history of rapid increase in the size of swelling. Moving on to the past history, patient is a known case of diabetes mellitus for the past 8 years, for which he is on medication. Patient is also a known case of hypertension for the past 3 years, for which he is on medication. There is no history of previous surgeries in past, no history of previous neck irritation, and no history of tuberculosis. Moving on to the personal history, the patient consumes a mixed diet with predominantly vegetarian. His appetite is normal, his sleep is adequate. He has regular bowel and bladder movement. Patient has been smoking for the past 63 years. Half a pack of cigarettes for the past 63 years, so 31 pack years. Patient has been consuming betel quid for past 63 years, 5 per day. And patient has also been consuming alcohol for the past 50 years. Moving to the family history, there is no history of thyroid disease or malignancy in the family. The patient also has 3 brothers and 1 sister. The patient's family consists of 4 siblings, 3 brothers, 1 sister, 1 elder brother and 1 younger brother have passed away. Cause is not known to the patient, and he also has 2 children, one boy and a girl. Now, summarizing the history, we have a 77-year-old male, chronic smoker with a smoking history of 31 pack years, presented with bilateral neck swelling for past 6 months and hoarseness of voice for past 3 weeks. The swellings are insidious in onset, painless, and gradually progressive in nature. He also complains of hoarseness of voice, which is insidious in onset and progressive. There is no history of dysphagia, dyspnea, hemoptysis, night sweats, fever, or weight loss. There are no symptoms suggestive of thyroid dysfunction.
You go back to the first slide. Okay, next. Okay, Robin, anything to comment? This is okay. I think we'll go to the next slide. Okay, asymptomatic mango notice both side neck and so initially small painless. Now it is not painful, is it? No pain at all?
No, no, sir.
Later the hospitals of void 3 weeks back, which was gradual and progressive persistent nature. Sir, Manoharan Sir, Robin, Keshav, Muthukumar Sir, anything to comment on this?
First thing is bilateral neck swelling, she said.
Yes, sir.
So both started simultaneously, both progress simultaneously.
Which one started first?
Which one started first?
Patient does not remember that. We tried asking him if it was more on right side or left side. He says no, it was same on both. One side at the both sides at the same time, and they were really small. And then they progressed to this side slowly until he developed hoarseness of voice, which led him to come to the hospital.
So that means history is not contributory. History is not contributing. Which side it came first?
We still not contributing because he was not clear which side he started first.
We tried asking the right side.
Simultaneously, is it? Okay. Otherwise, it is white. If it suppose the patient says one side it is started first and later other side, what it means for you? Suppose he says right side first, then later the left side. It is whether it suggests something for you? Or it has got some. So that's what Sir is asking, Sir is specifically one. Manoharan Sir asked very clearly, that's an important point. So why it is important? You understood the question, no?
Yeah. Yes, sir. The causes will be different if the swelling on one side.
Midline swellings would probably appear bilaterally at the same time, whereas lateralization could signify the right side of the region, wherever the first swelling appeared.
But here both sides, suppose one side appears first, the later other side, what it means? Probably primary is crossing the side. That's what Sir is Sir wants to find out, I think. No, Sir?
Yes, sir.
So that's when here you said it is almost the same time, not much difference in the appearance of the timing of the swelling on both sides. That's what you said. Probably it said that it is probably midline swelling, midline origin, probably primary. Sir, Muthukumar Sir, anything that Keshav, Robin? We'll go to.
So first, the swelling. Again, the laterality of the swelling. Second thing is the current size. How did they measure approximately 2 into 2 centimeters?
The patient showed me.
Finger breadth probably, na?
Yeah.
So I think in textbook it's usually written that way. They don't measure it, so it's either one finger breadth, something to, and you have not told us what the current size is. Just to be complete. That's all. And everything. Are we done with the history present illness?
No,
Some questions.
Yeah. So this is negative history. Isha, our question is, your problem, the patient's problem is swelling.
Yes, sir.
So everything about the swelling, the site, onset, character of it, the extent of it, relieving aggravating factors, these are all very important. No, it is exactly what Sir had asked. Manoharan Sir had asked the same thing. So did it start from somewhere? That is very important. That itself is one paragraph. So Bishop, can we go to the previous slide? Once that was done, no, the previous slide.
That's it.
Okay.
Yeah, after that,
if there is any aggravating or
that is 3 weeks back. That also we have to, because you're an undergraduate, right? So, and this is actually a very heavy case. So we are not going to obviously ask too many questions to you, but at least basics is what sirs are asking. So we want to, because from history present we want to know differential diagnosis as to a working diagnosis as to what is the neck is a very vast region, as you know.
Yes.
So midline to lateral and including the triangles of the neck. So we have to figure out everything too. You have given us symptoms, that is hoarseness of voice, let it be dysphonia, pain around the eye, ear, everything. All these are coming in this portion, head and neck region. So we want to know the spread of it also. So this has to be a little bit more elaborate.
That's what.
Okay.
But we never had pain, is it?
Yeah.
He does not report pain
Anytime.
previously or currently as a.
Suppose,
Like when we were taking.
suppose if you develop pain later, what it means for you?
Now
Could be an abs.
now or muscle infiltration could be present, sir.
Okay, any other reason to develop pain? Infiltration, yes. Necrosis, hemorrhage, other things will cause
Hemorrhage.
pain to the patient other than infiltration. It's progressing. When it progresses, it will cause the pain. Okay. Keshav, you wanted to add something?
I think
Infection.
this slide
Infection.
is lot of discussion because starting from first, immediately, why did you think about hypo or hyperthyroidism in this patient?
So one of the most common causes of neck swelling is first cervical lymphadenopathy, then thyroid, right? So we would try to rule out that.
No, that is not how we approach.
Even in
This
the lymph node should come first, no?
Yeah.
Those come from
According to you, you only said.
Keshav is asking why you thought thyroid in this patient.
Straight away, why did you think of thyroid? The swelling is in the upper neck.
And,
Yes,
and
Bilateral upper neck swelling, does it?
lateral neck swelling, no, not in the midline.
What is that you are thinking of in thyroid in this case?
So when you put a negative history also, you think
No,
okay, whether
because
it's really needed or not.
other things
It is totally different place, whether it's necessary or not. Okay.
Okay.
So throat pain, episodic voice. What is it? Episodic voice.
Episodic through a voice.
In which voice loss or hoarseness, it could indicate like functional or structural or malignant causes for larynx.
You said there is a hoarseness of voice. What is voice? Episodic voice loss. What
Without
episodic?
any inflammatory causes of laryngeal involvement, no, there's a hoarseness. So
It will be episodic, is it? Oh,
hoarseness would be episodic
hoarseness will be episodic. Okay, that's why you put throat pain. What is throat
in
pain?
early stages. Throat pain infection.
Okay.
So
Dysphagia, dyspnea. Why?
that's to look if there's any if it's there involvement of posterior half of the posterior third, 1/3 of the tongue, pharynx or esophagus.
Or look for the primary side for possible.
Any
primary.
sides if we are suspecting a malignancy.
Cough and hemoptysis.
That's for carcinoma lungs, to rule out carcinoma lung. If there are primary sources there.
Okay. Fever. Why you have asked for?
That's for tuberculosis, sir.
Huh?
TB.
Tuberculosis.
Tuberculosis.
Fever.
Right.
Fever, weight loss, night sweats for tuberculosis.
Okay. Night sweats.
Again for TB, sir.
TB.
Okay. Trauma. Why you want to ask for trauma?
There's like the sudden increase in swelling, like one of the causes for it. So if the trauma caused it previously and the patient is not
Okay. Rapid increase in
Trauma.
managed.
Trauma per se, bilateral swelling which is progressive, then how is it applicable? So, though it is listed out, you must be always, as Sir said,
honestly, sir, we should be able to give reason for everything, whatever you are
if
writing.
it is of a short duration, it's okay, but even then bilateral swelling related to trauma is little far-fetched, I think.
And no history of rapid. 6 months it has increased so much. It is rapid
Oh
only.
no, yeah, rapid for it is pointing out towards malignancy, but
But it's rapid increase.
also if there's like within like a week's period of time, if there's a hemorrhage, to rule out if there's cause for that. No? It's a sudden increase in size also.
You should have written recent rapid increase.
History of
Recent rapid. Yeah,
recent rapid
I
increase.
meant recent rapid.
Recent rapid increase in the size in view of the hemorrhage or something like that. Otherwise,
Yeah.
it's like Keshav rightly told, it's last 6 months it has progressed so rapidly.
It
both
is
sides.
already happened.
It has reached a significant size actually. So this last one word is really confusing actually.
And
Recent rapid.
okay, these are all pertaining to the swelling. What have you asked with respect to hoarseness of voice?
Have you not?
Why do you get hoarseness?
Episodic voice loss, sir.
But this is
Not
persistent.
episodic.
You said persistent and progressive, no?
Persistent. It's a persistent, sir.
Now, what are the things that can cause hoarseness of voice? For that, what history have you asked?
For any infection that is causing like a streptococcal infection, for inflammation.
For 3 weeks, continuous hoarseness of voice.
Hoarseness of voice. What are the possibilities? Abhay, you can help her, no problem.
Sir, hoarseness of voice could be recurrent laryngeal nerve involvement or tracheal
See,
involvement.
that is one aspect. That is direct cause of hoarseness of voice. The other thing is, suppose you have something in the secondaries in the neck. What have you asked history of the primary? Where is the most common primary? You got bilateral swellings.
Laryngeal primary.
Laryngeal involvement, sir.
Okay,
Laryngeal
laryngeal.
carcinoma.
And anything else? Can it be anywhere else in the oral cavity?
Tonsils, sir, could be.
Pharynx, nasopharynx.
So, what history have you asked suggestive of any lesion in the oral cavity?
Lesion.
Ear pain, you have asked ear
Difficulty
pain.
chewing. Swallow.
You understanding what I'm trying to tell?
Yes, sir.
Yeah, so in this, what you have enumerated, there is no evidence that you have looked for anything in the oral cavity. That's what I'm trying to tell you.
Sir, Muthukumar sir, anything to
You can
add?
ask for any
Yes, sir.
plaques.
Am I audible, sir?
Yes, sir, you are audible, sir. Clear, sir.
Right, sir. Right, sir. As sir has mentioned, you have to give importance for 2 things in this case. One is swelling, another one is hoarseness. Regarding swelling, you started with hypo or hypothyroidism. This swelling is, we are not bothered about thyroid. Hoarseness, we are bothered about thyroid malignancy. Instead of hypothyroidism, I prefer to mention about local effects of thyroid malignancy, not as a first point. For completion's sake, you can mention.
Yes.
You mention about dysphagia, dyspnea, hemoptysis. For completion's sake, you can mention about epistaxis, hematemesis also. Because you mentioned about dysphagia, you have to mention about hematemesis, hemoptysis also. Specific to sites of malignancy, you can mention about East Qatar. When will you get East Qatar?
And nasopharynx.
Nasopharyngeal malignancy. When you mention about epistaxis, nasal obstruction, and East Qatar also, you can mention. This is for the swelling. As Sir has mentioned, you have to give importance for change in voice also. Then only your presentation will be covering both the problems.
So that's what. Anything to comment, Robin? You go to next slide.
It's fine, sir.
Fine. Okay, next slide.
She has the checklist. She has completed the checklist for secretary. Yes. But the history of the illness should be
next slide.
more elaborate.
Okay. Here, hypertension, previous surgery in the past, previous neck. Why neck irradiation you ask? As a part of treatment, is it?
Yeah, there's a history of the lymphoma. They usually undergo neck irradiation part.
Okay. Which type of lymphoma they'll go for irradiation?
Hodgkin's.
Hodgkin's, okay. Secondary, neck secondary, so they will not go for irradiation, is it?
We can go for radiotherapy, so yeah. Secondaries, there are previous secondaries in the reports in the record now.
Okay, so anything to comment on this, sir? Manoharan sir, Keshav?
No history of tuberculosis where? What tuberculosis is better to mention, no? What?
Which tuberculosis you are interested?
Extra pulmonary.
Pulmonary tuberculosis. Why?
Pulmonary tuberculosis.
50% of the infections are caused from the adenoids, sir, tonsils.
Okay. That later we will find out. But tuberculosis treatment, pulmonary tuberculosis also maybe primary focus. So you specifically can mention which area you are interested to look for, think of. Okay, so it will not have general statement. You can have a specific area to mention, like Keshav clearly told. Okay, so we'll go to next slide, Robin.
Yes, sir.
Yes.
So next slide. Okay, smoking, scent, 31 pack here, cigarettes, metal plate, alcohol intake, everything. Yes, he has mentioned. Anything to comment on this, sir? Robin, Muthukumar, sir. Keshav, go to the next slide.
Yes, sir.
Yes, sir. Yes.
Logical factor.
Yes, sir.
Okay. Okay. Next slide. Okay. This is more or less. This is clearly she has mentioned why they
Yes,
Isha
sir.
or Abhay? Why did you specifically ask for thyroid? You have
Then
a
they were
point.
one of the most common causes of
Because
swelling.
we don't know where it is because you have not mentioned where the site is in the beginning.
Okay.
We want
This
the
is
site is very
upper.
important obviously, but why thyroid? This is the same question I think Sir had asked something back. Straight
Yeah.
away you
Okay, this is totally lateral swelling, no, Isha.
Lateral. Yes, sir.
Problem is because they what they think is they are not at examined. It's only history. So many neck swelling is classified time
Okay.
before initially told thyroid, non-thyroid. Probably somewhere they were taught like that, but it is not so. Like they should rightly told, this swelling is totally laterally. So again, Muthukumar sir has highlighted. Where thyroid takes a back seat in this this one. So you focus not necessary to focus on thyroid disease, but may not penalize because they are probably taught like that. But this is totally laterally. When you look at the figure, it is, I think, Keshav, Muthukumar sir,
Yes.
Manohar sir, Robin agrees because totally laterally, not closer to thyroid at all. Unless you would say that this is the secondary from the primary thyroid secondary here, occult thyroid, like that it may happen in such a situation. If you think of yes, family history, thyroid disease, and malignancy. Okay, other things chart they have put properly in family tree. That is good. So we'll, sir.
Isha or Abhay, Isha or Abhay, in the family history, like we have already mentioned, something relevant to your patient's problem. So, first and foremost, what is your working diagnosis in this case? In this patient?
Currently, from the history,
Yeah, from
you can go.
the yeah.
Since it could be either lymphoma or metastatic lymph nodes with the primary suspect
So,
in the larynx.
so you are suspecting maybe it's some sort of neck secondaries, maybe also lymphoma, maybe tuberculosis. Fine. So
Tuberculosis.
the points in favor of your working diagnosis would be
Yes,
like
sir.
I'm just trying to make it small. So one, age of the patient,
Elderly male.
gender of the patient,
Smoker.
the other predisposing factors that has resulted in this onset. Okay, this is more than enough to have an idea of any of these things. So the malignancy in the family, is it possible that is it important in family? Anything, you know?
So look at this. Look at this age.
There's a simple question, just we wanted to correct because you know when you ask thyroid and it's not a thyroid, like Sir has already mentioned, it's a clearly lateral swelling. Unless you feel the primary was here and then it has gone here like a papillary carcinoma thyroid. I assume you know this.
Yes, sir. Yes.
In fact, but the age of the patient is totally against that. Yes, you can also justify that probably, sir, it could be a lymphoma thyroid, but that which is very rare. Of all the malignancies, these come very last. With second last, which is just
becomes last.
history relevant to your case. What about tuberculosis?
Family stuff.
Yeah.
We asked, he didn't report any history.
Yeah,
No,
I mean,
neither for
like,
oral
only
cancer,
no
laryngeal
family
cancer.
history, so that is something that is contagious, which is running around. Now somebody is coughing and it goes to the other. Yeah. No, just to
He does not report
more
any
relevant
history.
actually. They will be
More relevant to the case would be because you know when neck is very heavy for you, you're presenting it well. Just make it specific. That's all. Yeah.
Okay, so currently
It's
considering the
actually
age,
case.
his habits, and the presentation of the swelling, we are suspecting a metastatic lymph node with suspected primary in the larynx. There's no history of the family history of oral cancer, laryngeal cancer, or figures in the family. So
Again, our question this is the same. Do you think this oral, laryngeal, all these things have a family predisposing factor?
Not really.
So simple.
More on habit, environmental based.
Yeah, more of them are more of dietetic and environmental factors.
Yeah.
So exactly, that's what we were asking. Yeah, that's fine. Okay.
Not.
Next slide.
Next slide.
Mr. Next slide. So summary again, same thing, painless, poorness of voice. Already these things are discussed. Fever, weight loss, suggestion for thyroid dysfunction. Again, she is again in the summary. She has mentioned thyroid because she was keeping thyroid in mind. It has been discussed here. It is summary better to avoid. During history it's okay, but summary should avoid that thyroid dysfunction. Okay.
What is Isha? What is significant in this summary?
Elderly male with chronic smoking history and hoarseness of voice, indicating laryngeal involvement.
First thing is elderly.
Yes, sir.
And then second thing is what is tobacco and
Chronic
alcohol.
smoker.
Tobacco and alcohol. Either orally and smoking, and then what else is got?
And the onset of
alcoholic also.
6 months
What do you
duration,
think?
painless.
What do you think with this history? Which system will be involved?
Head. Lymphatic system?
No, you only said tobacco.
Oh, yeah. There is history of butyl cord use.
Tobacco orally and is smoking also.
Yeah.
What are the systems would be involved? Just a guess. You have
Oral cavity, lymphatics.
One is oral cavity. What type
Oral
of
cavity, tongue.
what type of
Part
lesion?
of oral. Sorry?
What type of lesion? Tongue means what?
Tongue means what? Which part of the tongue?
Posterior half of the tongue. Carcinoma or.
Patient does not have any history or suggestion or no symptoms, no?
Yeah, patient does not report any
So
history.
what do you think without these symptoms, with this history, which part of the thing would have been involved in this, it produces bilateral neck swelling? Got it there, you have put it there.
Sir,
Insidious, progressive, dysphagia, dyspnea, hemoptysis, it's not there. Then
Yes, sir.
the thing is smoking for 31
Yeah.
years.
So we are assuming the squamous cell carcinoma.
Voice for 3 weeks, and he is a alcoholic also.
We are assuming squamous cell carcinoma, and we are trying to locate we are hypothesizing that he has metastatic lymph nodes, and we are trying to find out the primary source.
So where do this just a guess, squamous cell carcinoma, you said where?
Where is the primary?
Or larynx. Sir.
Right, we'll come to that. Proceed, no issues. Proceed.
Okay. Next slide. Next will go. Next. Okay. Abhay, you are presenting, no? Okay.
On examination, sir, on general physical examination, the patient was conscious, cooperative, oriented to time, place, and person. He was poorly built and nourished with a BMI of 17 kg per meter square. Pallor and lymphadenopathy were noted, and icterocinosis clubbing were absent. The pulse was 90 beats per minute, and the blood pressure was 160 by 80 millimeters of mercury. At the time of examination, the patient was afebrile. On local examination, the examination was done in sitting position with the neck region exposed to the mid-sternum. The 2 swellings were noted on either side of the neck, on the right side and the left side, and no other swellings were noted in the whole body. Moving on to the left side, moving on to the inspection, first the left side. A 6 by 7 centimeter oval swelling extending superiorly 1 centimeter below the mastoid, 4 centimeters above the midline of clavicle, anteriorly 5 centimeters from the anterior midline, and posteriorly extending till the posterior border of sternocleidomastoid muscle roughly. The overlying skin is red and shiny. The swelling had well-defined borders, and it did not move upward with deglutition or protrusion of tongue. The ear lobule is not elevated, and the external auditory canal looks normal. There were no visible scars, sinuses, or dilated veins, and the trachea appears central.
Any comment about the surface?
The surface was smooth, sir.
We'll just finish the.
Okay, continue. Proceed. Continue.
On the right side, on inspection, a 4 by 5 centimeter oval swelling extending superiorly up to the mastoid tip, inferiorly 7 centimeters above the midline of clavicle, anteriorly 5 centimeters from the anterior midline and posteriorly to the posterior border of the sternocleidomastoid muscle. The overlying skin is normal. The swelling had well-defined borders and it did not move upward with deglutition or protrusion of tongue. The rear lobule is not elevated and the external auditory canal looks normal. There were no visible scars, sinuses, or diluted. Palpation on the left side. All infectious findings were confirmed. The local rise of temperature was present and the swelling was non-tender on palpation. It was a discrete swelling with smooth surface with regular margins and hard in consistency. There was no fluctuation and the swelling was non-compressible in nature. Mobility, both vertical and horizontal, was absent. On contraction of the sternocleidomastoid muscle, the size of the swelling does not change. The skin was pinchable and no pulsations were felt. The swelling was transluminantly negative and on auscultation there was no broy heard. Next slide. Palpation on the right side. Here also all infectious findings were confirmed. However, there was no local rise of temperature and it was non-tender on palpation. It was a discrete swelling with smooth surface with regular margins. It was hard in consistency. No fluctuation was elicited and it was non-compressible. Vertical mobility was restricted, but horizontal mobility was partially preserved. On contraction of the sternocleidomastoid muscle, the size of the swelling does not change. The skin was pinchable. There were no pulsations felt, and the swelling was transluminantly negative. On auscultation, no broy was heard. Oral cavity examination. Mouth opening was normal. Nicotine stains were observed on the teeth. The tonsils and fossa could not be observed properly. Halitosis was present. The lips appeared normal. The tongue, there was no white patch observed on the tongue or the palate. Buccal mucosa was normal. Palate was normal. On bidigital palpation, right and left parotid ducts were palpated and were normal. The dentition was as on the screen.
Next slide.
The ear, nose, scalp, sinuses appeared normal. Laryngeal crepitus was present. The thyroid gland was not palpable. The neurological examination primarily focused on cranial nerves 7, 9, 10, 11 and the sympathetic chain were normal. On systemic examination, all examinations were normal except for there was bilateral basal crepitations heard on the respiratory system auscultation. The spine examination, there was no deformity, no tenderness, no paraspinal spasm and the movements were normal.
Next.
After examination, the two hard, non-tender, non-fluctuant, discrete cervical swellings were noted bilaterally in the region of the level 2 and level 3 of the lymph nodes, measuring approximately 6 by 7 centimeters on the left side and 4 by 5 centimeters on the right side. They were hard, immobile on the left side with restricted mobility and restricted vertical mobility and partially preserved horizontal mobility respectively on the right side. There were no pulsations and there was no change in size on the sternocleidomastoid muscle contraction. Transillumination and compressibility were absent. There was no abnormality located in the oral cavity or other regions of the body in the neurological examination.
Next.
So after the examination, I have provisional diagnosis is lymph node metastasis from clinically unknown primary, carcinoma larynx with secondaries, or lymphoma or tuberculous lymphadenitis.
We'll go to the examination, sir.
Yes, sir.
Okay.
First slide.
Next, now examination. Okay. Here, anything to comment? We'll straight away go to the next slide, Robin. Next.
Abhay, lymphadenopathy is plus which lymphadenopathy? Generalized lymphadenopathy?
No, sir. Only neck lymphadenopathy. Sir.
Yeah, usually for general physical examination, we Pickle mentions general lymphadenopathy, right? Or you have to be specific as to what it is. Huh? This is like a general term.
Yeah. Otherwise, tell the cervical lymph nodes will present later. We'll mention later. We'll mention like that. Okay.
Just to finish it here, Abhay, just because you question on lymphadenopathy, what are the watershed areas of the body? Where do you expect to see lymph nodes? whether it is a cause of maybe benign cause of lymphadenopathy, infective inflammatory, neoplasm, whether it's benign or malignant secondaries, जो भी है, what are the watershed areas where you can find? How many are there? 1, 2, 3, all of them.
With all regions you want to examine, that's what exactly Robin is asking, I think.
So one is neck examination, sir.
Okay.
The neck lymph nodes.
Yeah, okay. Then?
One, the epitrochlear lymph node.
No.
Supraclavicular lymph nodes.
No. Supraclavicular comes under neck.
No, you said neck. What next?
1, A, B, 2, 3, 4, 5, 6, 7.
What next? What next? After neck, what is there below? Below.
Axillary lymph nodes.
What groups? Yeah. Groups
And
of
the inguinal lymph nodes.
Abdomen, axilla, abdomen, inguinal lymph nodes. So all these regions will cover in generalized lymphadenopathy. So better to specify here.
You should know these three. It's very easy to remember. Sort of, we teach students. These Christians know how to draw the cross. A cross like this. It's a vertical line and a horizontal line that comes this way. So the sagittal plane splits into two. That is why Sir had asked one simple question: was it unilateral in the beginning, and then did it become bilateral? It's very important. You should know. Lymphatics is a very interesting topic. You should read it. Actually, just read SRB Sir's book. It's more than enough. Everything A to Z is there. One is a vertical plane and the other one is a horizontal plane that splits this way. So you have something above the clavicle, below the clavicle, then comes the umbilicus, below that is the inguinal.
Three regions, no? That's what.
Three watershed areas, yes. Okay.
That's the point you have to remember. So we'll go to the next slide. Okay. Two swelling noted right and left side, no other swelling noted in the body. We'll go to the next. Right. This is, I think, all of you will take, I think, a lot of comments will be there. Keshav?
Yes, I think from what the picture, the swelling is much behind the posterior border of sternomastoid, isn't it?
Yeah.
And if you could probably, I think there are some inflammatory signs on the
Left side.
swelling.
Left side.
It's a quite large actually, quite large. Almost
Some erythema is also there. And what is this in the lower part? If you can clearly see, there are some lines, no, going from the swelling.
Yeah, what are those lines called? What that sign called?
From the swelling towards the clavicle.
You see the wrinkling there? What is that wrinkling, Abhay? What is the cause for that?
That's and it's very typical of certain swellings. I think you should.
Very typical of that. What it means? See that very nicely seen there. Very nicely seen. What is this?
I don't know, sir.
Okay, Isha, anything you know?
Yeah, no, sir.
No, that is called a platysma sign, I think, Keshav. That's what it is involved platysma. It's a clear, it's a very typical sign. That is called platysma sign.
Signifies the involvement of platysma.
It's very typical, very typically seen in the secondaries actually. Malignancy. Okay. Then
here,
no sinuses, brachypers, this one, well-defined border. And movement to the nutrition and protrusion of the tongue, so lateral again.
I think everybody should comment on that.
I think
Yes.
you can remove that line.
no, they are very fond of thyroid. Either one thing.
Laterally placed.
However, they keep
You
talking
did not
about
mention
thyroid.
about movement with the deglutition.
Not applicable.
That too, not applicable. Protrusion of tongue? No. 100% no.
Protrusion of tongue not at all. Yeah, there is, you should not look at the picture.
This is upper neck swelling, level 2 swelling, where how much up it can go? It is at the top of the neck.
True.
When mention about earlobe is not elevated,
Yes, sir. Yes.
And
you are trying to rule out parotid.
Parotid,
You
yes.
can also mention about retromandibular groove obliteration also.
intermittent groove obliteration also.
Two things to rule out parotid or to confirm parotid.
You don't require to prove that it is not thyroid by telling that because it is so lateral.
Yes.
This is what probably they want, but never protrusion of tongue, I think.
Never.
We never expect that to happen here.
It has to be midline swelling. It cannot be lateral.
Lateral at all. Okay.
Like
Yes.
Sir said the ear lobule. Okay, just because you see whatever you put, we will ask question. Till then you are safe.
Okay. So
Okay.
next slide.
Is it possible that any swelling is there where the ear lobule will be raised? No, sir has given you a clue that's parotid, but we want to know what specific in parotid will cause this problem in this region.
What specific lesion? This one.
Sir, any inflammatory lesion of the parotid or a malignant region where the size of the gland
No, that is a very diplomatic answer. It's like, ye bhi le lo, wo bhi le lo. We can't accept that solution.
Both, no. You are telling inflammatory and malignancy. Both you are telling.
We can't choose, guys. Come on.
Diagonally opposite. One is very safe. Malignancy is not safe.
Whatever it is, do you think parotitis will go all the way here? It will go all the way here and occupy the level 2 jugular digastrics. Okay, so you're saying, let's say neoplasm, benign or malignant. Do you know anybody that can cause this problem here at level 2, not here? Usually all your parotids are here only, but this is here.
Preauricular lymph nodes?
Pre-auricular, Isha, pre-auricular, yeah, it's here.
Okay.
No, sorry, that is different. We are talking about way down level 2.
Level 2.
It is
Is it
rather
Body cervical, right?
parotid tumor that grows somewhere else, a specific region? Anatomically, any name for it?
yeah. And here, this side, ear lobule is not elevated. Are you sure that the figure? Look at the figure; it is elevated actually.
Elevated.
Sir, I think
Whether it is parotid or not,
right side is elevated, left side is not elevated.
right side is elevated. You said you are not elevated. Isha, you got some confusion. Look at the figure.
Here also the skin platysma.
Ear lobule is raised like this.
Yes.
So
Viral infection.
okay, it is elevated.
See.
So whether it is parotid or not is a different debate. But finding clinical finding is very obvious.
Yes.
It is said that it is pushed nicely. Okay, here also platysma sign is seen actually. That wrinkling, that's the typical platysma sign. Okay, where platysma is involved. Okay, so overlying skin is normal here. That's what probably okay. So we'll go to the next slide.
Left side is more a little, I think skin is reddish and inflamed like.
Left side is larger. Left side is more involved.
Involved and skin appears to be stretched and little inflamed, reddish, I feel.
That gives us some idea that probably this started on the left side, then crossed to the opposite side. Probably that is the interposition we can have because left side is bigger than the right side. Isha, Abhay?
Yes, sir.
Yes, the left side is much bigger.
Could it be submandibular gland involvement?
Okay, so sir, we'll go to the next slide, sir.
Yes, sir. Yes, sir.
Okay, next slide. Palpation again, non-tender, no locus, non discrete swelling, hard consistency, fluctuation, non-compressible.
I think once the student tells it is hard in consistency, I think the next fluctuations probably should not come because there is no hard swelling that can ever fluctuate, isn't it?
Okay, that's what
Fluctuation and translimation can be omitted. Translimation also you mentioned.
Sometimes tumor necrosis or some occurs, fluctuation can occur, but it will be softer, not hard.
That will be under variable
consistency. In that situation, you have to tell which is variable in consistency, then some part is fluctuant, probably due to tumor necrosis and so on. Here you said the entire thing is hard. You said smooth surface, not even nodular.
It was smooth only, sir.
Okay, no, we are not questioning your finding. We are telling. Then how fluctuation comes into the picture? That's what Keshav Prasad is asking.
See, you are adding things
look for
which
compressibility.
you give one example of a swelling that is compressible in that region that comes like that bilaterally. Is there any hard swelling that can be compressible like
Why
that?
you have mentioned non-compressibility, keeping what in mind you are thought of? Which are structures which are compressible?
Compressible swellings of the neck, lateral.
Anywhere you tell.
Tonsils.
Anywhere compressibility suggests what? First thing comes into your mind what?
Cyst.
Swelling, sir.
Cyst.
Huh?
Cyst, sir. Could be
compressible.
a branchial, compressible cyst, branchial cyst.
No,
It is fluctuant, not compressible.
You should understand what is compressible.
Compressible has to go
Carotid body tumors.
back to original size.
Carotid aneurysm.
When pressing it goes, reduces in size and comes back to original size while releasing. That is the meaning of compressibility. So, by principle, the first thing you'll think of is a vascular malformation.
vascular malformation.
Vascular
Okay.
swellings.
Mangiomas.
We are not suspecting any vascular malformation in this patient. So, So that mentioning is skin. He said skin is pinchable left side. This is skin.
Yes, sir.
Are you
Yes,
sure?
sir. Although I could see the induration, there was tenderness and there was increased warmth and palpation also, but the skin was
Not
pinchable.
tenderness. You said non-tender.
No, sir. There was local rise of temperature, sir, on the left side.
That is there, but this skin doesn't look like.
So the stretch, the skin is fully stretched, I feel, sir.
Skin is fully stretched. What you are pinching?
Tiny also.
Tiny, hyperpigmented.
Because platypus is inward and skin is red, looks like adherent only. So your pinchable skin is because we are not.
Don't agree.
See, just reconfirm that this skin pinchable is rather questionable. No pulsation, but translumination. Why you wanted to check translumination here again? It will be unhappy only.
Please. Just for completion, sir.
Yeah,
No,
complete.
just
Completion means it should be applicable, no?
it should be relevant. It is not irrelevant. No, you can't just.
You're talking about a cyst or collection of fluid, you can use all these things.
Translumination, once it is fluctuant, you will tell translumination. You said not fluctuant, you said all those things, then you will do translumination. You will not do the translumination if it is not fluctuant, no? If there is no fluid, why you want to do it? Okay. So that is the thing. So bruit absent, okay, why you want to look, bruit is auscultation, no? Why you have put here?
Sir, I said, sir, occultation only, separate fluid.
This is in the auscultation. Thrill is okay. You can palpate for thrill. You probably by mistake you have put bruit here. Bruit comes under auscultation. Thrill, yes, you can put here a thrill. That there bruit you can later in the auscultation, not here. Okay, we'll go to the. So there are so many things. Little bit some small things are quite important.
One thing you could have added the no visible veins over
Sir, I added, sir, on.
Here, impression he has mentioned, sir.
Okay, sir. Thank you.
He has mentioned, sir, impression. So the skin is a fluctuation, compressibility, bruit is a malformation. All those things are these negative things you can always avoid actually in this case specifically because it may not be relevant, like applicable. Like the right sir has rightly put the word not applicable. Okay, so because finally you should be able to give a reason for everything whatever you are written. You should be able to give clinical reason. You should have a scientific justification for whatever you are thinking. Okay, that is the whole exercise. Okay, so we go to the next slide. So right side again, no fluctuation, no compressibility.
Same.
Skin over the pinchable, no pulsation, translumination. Bruit again, you put bruit here, probably by mistake, but bruit comes under auscultation by not in palpation. Okay, so
The contraction of the sternocleidomastoid muscle, the size doesn't change, or does it
It's a
become
deep one, it will reduce, sir.
how is it the size or
So the size of the swelling does not change, sir.
so there is a space here in the neck where the size can become more and something like a hernia where when you increase pressure it becomes more, something like that, or
No,
this is a muscle.
If it's deep to sternocleidomastoid, it
Basically,
will reduce.
diagnosis in neck swellings, which is the most common diagnosis in a neck swelling.
Cervical tendinopathy.
No, just lymph nodes, basic lymph nodes.
Lymph
You have
nodes.
approximately 800 in the body, of which more than 300 are here itself. Na? The rest of them are all located downstairs. So
What
it's all-
sir is? Yeah, I think sir is trying to tell that instead of telling it reduces, instead of that you can tell it's less prominent.
yes, the prominence. Yeah.
the less prominent like that. I think that's the right word you have to use.
It's a solid swelling you are telling, it cannot reduce or increase, no? It can only become less prominent or more prominent if it is superficial to sternomastoid.
Probably it's works good for any muscle, any swelling in the muscle. You use that word only. Okay, whether it's attached.
It's a better idea that what you are looking for instead of just telling reduces. No, reduces it is not a technically it cannot reduce.
Okay.
Isha?
Yes, sir.
Is there any swelling? This is not in the midline, we all agree. It's somewhere in the lateral portion.
Lateral.
Keeping that point in the contraction of the sternocleidomastoid, is there any swelling in the lateral thing where this, it can appear and disappear, or
Could be. If it's located deep, it will reduce in size, sir, and if it's
No, we just want the diagnosis.
example.
We just want to, yeah, exactly. We want a diagnosis there.
Yes.
If you have a little
Not
lateral
this case.
Expansile would be a laryngosele or a carotid aneurysm. Carotid body tumor would be
a carotid body
transmitted.
tumor or a carotid artery aneurysm will appear and disappear.
Disappear, is it?
No.
Will appear and disappear.
Pressure. So it should be something which is there in this adjacent area, right? In this portion.
I think she mentioned that.
Linoceal.
Part of the
Laryngosele.
diagnosis are told.
Expansile. It has an
Okay.
expansile.
Expansile. Okay, no, just just be careful always what you write. Whatever you tell us, we will ask you questions based on that. Neck is a very vast thing. We can ask whatever we want. Yeah, these are very yeah. Okay. Yes, sir. Sir, we can go to the next one.
Next slide.
Brui is very dangerous. Yeah.
Oral cavity exam, mouth open.
The other, you have not mentioned, we have palpated for other lymph nodes in the neck.
Other levels you have mentioned, palpated, no?
Sir, I palpated, I just didn't mention, sir.
Very, very important, no? We have got swelling in the lymph node area. We want to see other lymph nodes. It has
Other levels, probably they have mentioned somewhere. I think that's what I thought. Okay.
No,
I didn't
You have to
mention.
mention other levels. You specify level 3, 4, not there. This is probably level 2, 3, level 4 and 5. Okay.
For completion's sake, you could remember about this laryngosele, pharyngosele. So is there anything you will do clinically to demonstrate those two things?
Pharyngeal pouch and laryngosele.
Pouches, laryngosele, pharyngosele,
See, laryngosele is common on the right side. Pharyngeal pouch is common on the left side.
left side.
Okay. So, trumpet blowers it is common. No, not very common. I have seen only 2 cases until now.
That's it.
So one patient from
maneuver will elicit. What maneuver will elicit that?
Valsalva, sir.
Valsalva, okay. You can blow,
Blow.
to become more blissful. Okay, so vital palpation, right and left world, that's not palpable. Buccal mucosa, palate, tongue. Halitosis is present or absent?
Present, sir.
Present, huh?
Present.
You told present, but you have written here absent.
I said, sir, probably when I did this.
Okay. I heard you are telling present.
Yes, sir.
You are written here
Present.
absent. So I just want to clarify it. Okay. Okay. So dentition, okay, it is clear. So there are some tongue fissures are there actually. So you can see the tongue fissures in the tongue actually. Next, you go to the next slide.
Yes.
So proper oral cavity exam is important, remember. So here no laryngeal crepitus here normal, is it?
It is normal, sir.
Absent, what is called this? What
Present, sir.
What sign it is if it is absent? Any name for that? Thyroid not palpable, then neurological examination,
You
spine.
can add salivary gland examination also. Can you add salivary glands you can add. Parotid and submandibular. But not bilateral.
Have you palpated oral cavity, Abhay?
Yes, sir. Yes, sir.
Okay, put the finger and
Yes, sir.
okay. For ulcer and indication, you have to palpate the oral cavity.
Yes, there was no indication. There was no lesion.
Okay. So
The checklist for examination of a neck, you start from head and neck, full skin from above, everything. Eyes, ears, oral cavity, neck, everything full all the way. Then we go down to the breast tissue, thyroid, breast, lungs, that way, yeah. Above downwards.
it's what? Any neck lymph node, oral cavity, head, scalp, ear, nostril, sinuses, everything you have to look for. Understood?
Last abdomen.
All drainage area should be examined. Okay.
Abhay, which is a cranial of 13?
By mistake, 12. I observed it. It is should be 12.
Yes.
There is
Lower, you're right about what you mentioned. There is lower cranial nerves 4 and sympathetic chain for Horner syndrome. 9, 10, 11.
Sympathetic chain, what you are looking for?
Horner syndrome, sir.
Horner.
I'm looking for ptosis and what's this.
Sorry?
mainly Horner syndrome. Okay.
Includes
Mainly
what?
spinal accessory, hypoglossal nerve, Horner syndrome. The 3. Okay. The 3 things you have to look for. Mainly 3 nerves. spinal accessory, hypoglossal and Horner and sympathetic chain, that is Horner syndrome. Okay. So we'll go to the next slide, sir.
Yes, sir. Yes, sir.
Yes, sir.
Sure. Okay.
Yes, sir.
Summary again, no change of size on contraction. That is again translumination, compressibility. We already debate. No need. Other regions of the body, it's okay. Neurological examination, heart swelling, size, left side, right side, non-fluctuant, discrete cervical lymph node, hard, yes, told, too hard, not tender. That should be eliminated, should be remote. Okay. So summary. Okay. Next slide. Diagnosis, sir. Manoharan sir, Muthukumar sir, Keshav, Robin. Anything to comment on this, sir? Primary.
CP was okay, but carcinoma larynx with second.
Why? How they centered around larynx?
Yes.
No, sir, just because of hoarseness, sir.
Because
So
what's
just-
the voice?
Boldness of voice, sir.
That's
Right.
persistent.
What you should remember is lymph node secondaries go in a particular fashion. They drain a particular area.
Area.
Larynx, level 2 lymph nodes will not be draining larynx. So you cannot add this plus that because there will be two different things.
That's what where maybe the primary.
Sir, level
You're
3,
suspecting.
but sir, can level 3 be draining lymph nodes, sir? Like level 3, we're not sure if it's level 2 or level 3,
It's
sir.
gone to the 3, accepted. Left side has gone to the 3 actually.
Because left side it was too big, sir.
Yeah, right side level 2, left side level 2 and 3 both ignored. So other than larynx, do you think anything else? That's what Keshav is interested. Just
Sir, it
think.
can be all hidden areas, sir. Could be nasopharynx.
Look, you-
No, boldness of voice you have to take into account, no?
Hoarseness means you have to take into account the recurrent engine of hoarse. The course of the nerve you have to remember.
So the only clinically, so history wise, we were suspecting the primary to be in the larynx because we cannot clinically find out any other primary sites like oral mucosa, tongue, or cheek affecting it. So we are assuming it to be in the pharynx, esophagus, but since the history is eliminating all these things, so we are just hypothesizing it to be larynx at this point. We'll have to go for investigations.
Not only history wise, even inspection and wise also oral cavity appears to be normal only, no?
Yeah, so
It is normal.
it's clinically not visible.
There is no lesion in the oral cavity or the posterior 1/3 of tongue. They have mentioned unknown primary, that means occult primary. So where you will look
Yes,
for?
sir. Fossa proximal lateral wall of pharynx, posterior third of the tongue, pyriform fossa, thyroid. No, not thyroid. No, sorry.
Both are so fond of
No.
both
In the differential diagnosis also, you have not mentioned anything about thyroid. That is good.
Sorry.
That is good.
Can you tell me what's the difference between occult primary and unknown primary?
It's a clinically
Are
unknown.
small.
The occult means what?
Occult primary.
The occult.
Occult primary is after investigation when you don't find the primary, that is occult primary. Unknown primary is after examination when you don't.
It's a clinically unknown and occult are same. Clinically unknown is different. Only after clinical examination. Okay. What all available investigations, imaging, if primary is not identified, then it's called occult or unknown primary. Okay. CUP it is called CUP, carcinoma unknown primary. Okay. So lymphoma, why you are thought of? Tuberculosis, why you are thought of?
The bilateral painless lymph node enlargement where there's no history of like being one-sided. Patient reports it to be both sides with considering his age and
Tuberculosis, why you are thought of?
consistency of TB lymph node
Consistency, what is the consistency in the
Matted.
lymphoma?
mattered.
India rubbery.
And again it will be mattered as you said. Here it is a
That's
single.
TB. So the matted lymph nodes would be different from lymphoma.
In which other condition you will get mattered?
Which condition it is matted? Lymphoma is a
Granulomatosis disease. Any other granulomatosis disease? Sarcoidosis? Can that cause?
sarcoidosis or tuberculosis matted?
Tuberculosis is causing matted lymph nodes. Besides that, I was.
Why there is matting?
Due to periadenitis, sir.
Periodic.
Periadenitis, sheeting necrosis.
So tuberculosis lymph node is matted. lymphoma is usually firm and India rubber.
Usually.
India rubber.
Mechanisms are hard. So that's how we usually clinically give a diagnosis.
So malignant nodes in advanced stages may be matted.
Yes.
It may be hard inconsistency. So
They may be hard, they may be adherent to each other.
Each other.
Matted word is specific for tuberculosis.
tuberculosis.
By principle, clinically at least. Okay, so you have to use that word very carefully.
Abhay,
Yes, sir.
guys, just it's very easy to remember, like what, just to reiterate what Sir has asked. 4 reasons for matting, causes for matting. It's always when an examiner asks you some question, think very simple. It's like what they say, think very silly. Benign neoplasm. That's it. Benign simple things like infective inflammatory problems. So you have acute lymphadenitis, reactive lymphadenitis, tuberculosis. Simple things. Already Sir has said. Initial stages myocarditis and then slowly to consistency changes. Then malignancy, 2. Commonly secondaries where you're really firm and shorty ones. Second one, lymphoma, like you have mentioned. Yeah. So you have 2 benign, 2 malignant. It's very easy to remember. And just to ask what Sir has asked, what is the reason for this matting? In maybe you can just give us 1 or 2 words, then we'll understand that you know.
Sir,
Why does it mat?
Sir, that is due to
Coalescing.
Sir, coalescing, sir, due to periadenitis, there is sticking of the lymph nodes, sir.
No, those are stages for
Cacheating
lymphatic.
necrosis,
I don't know why
they coalesce
cacheating
after
is a very high-fi term. We have cacheating necrosis different, tuberculosis spots different. Both are a bit different.
Different types are there, no? Caseating type, hyperplatic type, atrophic type, like that. Okay, so caseating tuberculosis with the periodontitis, it causes the matting. Okay, so that's the reason.
Please read the anatomy of the lymph node. It's very, very interesting. It's something to do with subcapsular sinus. All these guys stick together. The minute one breaches, goes to the other guy. Both it's like a love story. Both they stick to each other. It's very, very interesting. Actually, there's a beautiful diagram. It's like a kidney shape. I assume you know your example. So, yeah, the cut section is very interesting. Where the vessels come in and where the sinus comes, how it gets infected, inflamed. Yeah.
And it is complicated also. Lymph node anatomy is complicated actually. You got a wide blood for all those things. Okay.
Yes, sir.
Go to the
Next slide.
next slide. Okay, investigations.
Sir, in investigation, we'll do a routine checkup consisting of CBC, LSP, RSP, thyroid function test, and blood sugar just to see the performance status and the overall and health of the patient. The specific examination we'll do a serum LDH for the lymphoma, chest X-ray because the patient has been smoking for quite some time, and I could hear bilateral basal repetition, sir, on examination. Then we'll start with indirect laryngoscopy and an ultrasound of the neck, which can help us with SNSC of the lymph node. We'll do a CECT of the head and neck. Indirect laryngoscopy can be included with fine endoscopy, which includes upper GI endoscopy as well as another endoscopy. And if we can find we can do biopsy of the areas. If all of them we're not able to find them, then we'll go to the next step.
Now, why serum LDH?
Yes,
Sir, serum LDH is the marker for lymphoma, sir.
Lymphoma is not your first diagnosis.
No, sir.
Then it should not be there. It should be down.
It will be down, I think. If you don't mention also, it's okay. We will forget. Don't worry. Okay. But indirect laryngoscopy for hoarseness of voice. It can be a video laryngoscopy also, so that you can take a biopsy also. Endoscopy under anesthesia is accepted.
What do you mean by pan endoscopy?
The pan endoscopy will do 3 endoscopies, sir. Laryngoscopy, direct or indirect, preferably direct. We'll do bronchoscopy, sir, and we'll do upper GI endoscopy, sir.
What about nasopharynx?
Nasal.
Sorry, bronchoscopy, sir, is optional.
Nasal.
We'll do.
Nasopharynx. Nasopharynx.
Also, you have to do nasopharyngeal, bronchoscopy, and cephagoscopy. Okay, let's see.
Which is missing here in your list of investigations? Nowadays, what we do?
What you will do? So why you want to do ultrasound get a FNAC? You do ultrasound, see the other nodes like who Keshav told other lymph nodes you are not look for. So whether it is level 4, 5 or there or not to identify, even though clinically not palpable, they may be enlarged. they may be significant. That's why you do ultrasound. FNAC can do slightly.
Ultrasound guided FNAC is invasive.
Yes.
Without knowing anything, straight away putting a needle is not advisory right now. So you have to do other things. Any other thing you want to do from pathology department?
Very important for now. You should know for new generation.
Immunohistochemistry?
Very good. IHC?
Very good. Yes.
Cytohistopath. To look for Epstein-Barr virus or any other infections.
So many things, even for malignancies.
Epstein-Barr virus.
Lymphomas.
Okay.
Before your FNAC, before your FNAC, do the IHC markers, they will be doing something. Narrow down your diagnosis systems. Then you plan for other things. Suppose FNAC comes as squamous cell carcinoma, what you will do? If it is coming as adenocarcinoma, what you will do?
Next slide. Okay, slide, forget about slide. You answer the sir's question.
You have done FNAC, MH guided, according to you. The report comes as squamous cell carcinoma.
What is your plan? If it comes as adenocarcinoma, what is your plan?
Adenocarcinoma, what is the plan?
Treat the primary sites.
What are the chances? Among these two, what are the chances for getting as a
Adenocarcinoma would mostly come from a GI thing, right? GI involvement would also be seen in adenocarcinoma if it comes out, but squamous cell would mostly involve the oral cavity.
Your relation is in the neck,
Neck, upper part.
upper part.
Tell the size of squamous cell carcinoma. Tell the size of
Yeah.
adenocarcinoma. That's all.
One or two.
Tonsils, so adenocarcinoma.
Adenocarcinoma, tonsil,
No.
All this time, both of you are talking.
carcinoma, lymphoma can occur in the tonsil.
Yeah, sorry about that. I'm just taking again.
Tonsil mainly carcinoma, squamous cell carcinoma. Carcinoma,
Tonsils is
lymphoma.
carcinoma. I'm not sure about adenocarcinoma.
Adenocarcinoma is glandular.
And what are the glands there?
Both of you are fond of one gland.
Thyroid.
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 Thyroid, no.
Okay.
Thyroid, you have been telling
Both of
thyroid.
you are hanging on thyroid now. When it is necessary, you left the thyroid. What is the other gland in the neck, head and neck?
Head and neck.
Salivary gland, sir.
Salivary glands.
Salivary glands.
Salivary glands.
Salivary gland,
Any submarine.
thyroid. Then of course, other areas also you can find out. Okay?
So what if it is squamous cell carcinoma? Why? So chances are more, which is more common? Squamous cell or adenocarcinoma?
Squamous cell carcinoma.
In your case, you are in favor of squamous cell carcinoma.
Squamous cell. 80% of neck tumors are squamous
Squamous
based.
cell. The split is often squamous cell and non-squamous cell. 80% are squamous cell, right? Sir, rightly told. Okay. So
So
that's
now
important.
you have this patient who's got bilateral fixed hard lymph nodes. So what is your intent of treatment?
So we'll be proceeding with the neoadjuvant since they are fixed.
Wait.
Yeah.
What's the diagnosis?
See the listen the question. What is your intent of treatment?
Oh, intent. We will have to undergo since they are fixed in
Intent whether curative or palliative. That's what.
curative currently.
Intent means you have to tell that answer. Well, you are going to
Okay.
cure this patient.
Curative, sir, not palliative.
You are going to cure this patient.
Yes, sir. Curative.
Oh,
Early or advanced disease.
advanced disease.
You are going to have a oncological clearance by some means. This patient. Abhay, same. You are also agreeing with that.
No, sir, we'll do it will be a palliative treatment, sir. We'll make the nodes are fixed. We'll try to make them not
What is the correct?
because
You said
they're-
bilateral.
Abhay,
they're not, yes.
Abhay, correct way to answer is what I will diagnose first. Then I will do the staging. Is it not? First you will diagnose what it is. We don't know what it is yet, according to you. Then we have to stage the disease, how far it is. Then based on that, we will decide what to do. If it is possible, we will do a down staging. Otherwise, if it's already patient is having hoarseness and all, nerve involvement is there. Isn't it?
Depending on the stage, you decide. But this is what stage, end staging, if you said
N3, if we go for
but it's fixed, not, it said it's not mobile. You
it's
said it's
fixed.
fixed anteriorly to the sternocleidomastoid muscle, posteriorly it is fixed to the muscles there, preorbital muscles, left side. The non-mobile you said.
Yes, sir.
Okay. Okay,
What is it?
suppose it is early stage bilateral. If you want to do surgery, what surgery you will do?
A radical leg dissection, sir.
Both side?
Both sides.
Yes, sir.
You will remove IJV both side?
No, sir.
No,
No, sir.
IGV.
That
What is radical? What is modified radical?
So in modified radical, we preserve the spinal accessory nerve, internal jugular vein, and sternomastoid.
So,
One of-
Sir is
one
asking, can you do
extent.
bilateral radical resection?
Only the spine will, cervical spine will remain. If you do radical on both sides, only the cervical spine will remain.
Everything will be removed.
Everything will be removed.
Only cavity is retained.
Then we'll go for the
IJV, you are
modified
taking,
ones. IGV, you will retain one side, so that would be a selective neck dissection then.
Which side you will do first?
First.
Suppose if you want to bilateral.
We'll preserve the side that does not, but
Other side.
it's bilateral.
Okay.
Theoretically, we're supposed to preserve the one that's intact, but
Will you able to cure this patient?
no.
Only palliation you will do.
Palliation,
What is
okay.
the end stage of this patient probably?
Palliative care, radiotherapy is a post neck treatment.
Terminal events of this patient, what are the possibilities? In this
Terminal.
Aspiration.
aspiration, okay. Why you should aspirate? Because oral cavity normal is it?
Yes,
Other than larynx, if it is the larynx, yes.
yeah.
Mostly hemorrhage, erosion into the
Hemorrhage.
carotid or somewhere else there. Because
Malignancy, always think about adjacent structures.
adjacent factor locally, that's what important, that's right. So,
So if it is histologically squamous cell, any advantage?
They are good prognosis.
How?
Advantage. Treatment wise.
advantage, which is better?
Advantage of being squamous cell carcinoma.
Adenocarcinoma, squamous
No,
cell
radio sensitive, sir.
No.
Very good, very good. Radiotherapy. So,
squamous cell carcinoma is always better than adenocarcinoma.
so that means you can reduce the size of the tumor. It is fixed, it is not mobile. So adjacent structure radiotherapy can help to some extent before, before doing your surgery, you can do that and then plan for these things. Okay. Other than CT, you want to do anything else?
Other than surgery, anything else you want to do? Chemotherapy? What drugs?
Cisplatin mostly. 5-fluorouracil will be using, or these are the most commonly ones used for this type of metastasis malignancy. But besides these, you can also use adriamycin, cyclophosphamide, methotrexate, taxanes, docetaxel.
Okay. So she has become oncologist.
Oncologist.
Okay, no problem. Good.
2 minutes.
Okay. Sir, anything to ask? Meantime, I'll just run through the slide, Subiksha. Just run through the slide. Robin, you can
Plane of the swelling may not be very, very clearly defined in CT. So
MRI, sir.
the MRI, if needed, it's a multidisciplinary approach. It's not that only one person.
start my slides, my PPT, Subiksha. So, sir, Robin, Muthukumar, sir, just how they presented and brief for this one. Meantime, I'll start my slide.
Right, sir.
How they exactly presented and how they should go ahead with this brief one.
Before.
Anybody, sir? Keshav or anybody? About that.
They mentioned everything, but we should be in a particular order. You have given importance to less important points. That order should be changed. Otherwise, it is complete, sir.
They presented well, certain things should have been
So
this
it's
one.
a PG case, to be honest.
Difficult case, I know.
They have done well, sir, but the only thing both of them are sticking to thyroid most of the time. Always highlighting the
But
thyroid.
I think they are taught like that, thyroidal, non-thyroidal. So they have to prove that it is not thyroid. So every slide they mention thyroid. So you have to use your discretion in individual case to case. The clinical
Run through is good, confident, and they are able to face.
they prepare the slides well and
So that we have to give appreciation.
difficult case. Because thinking for that analysis. Otherwise they have done well. But Robin, you got some comments on their thing.
Keshav sir. Keshav sir.
Keshav.
No,
You can have a comment, honest comment, no problem.
Yeah, like sir mentioned, I think the order of presentation and somewhere focus on what is important would be better, I think. It's okay.
That's what. Robin, sir, I'll just quickly.
Isha and Abhay, good presentation.
Yes,
You
sir.
have taken a, it's like Sir, as Manoharan Sir has said, you have taken a postgraduate topic and made it a very good presentation. But just to be on the side of my faculties and my teachers, please be specific to what your patient's problems are. Just because the textbook says ki non-compressible, non-reducible, no.
Sir, that's what. Everything there in the textbook, but individual case you have to use your discretion whether this is correct or not.
You cannot give us an explanation to the Viva teachers that ki we did it out of completion sake. No,
Yeah, that's what.
that is not an answer to that question.
So,
And always the chief complaint. Now, this is a classic case of a lateral swelling, no doubt about it. And unfortunately, you have a bilateral neck swelling.
that's what.
So you should know what are the causes for bilateral neck. You should know the indications, if at all, that Sir has asked for bilateral neck dissection. What are the complications for the just by the time Sir loads the PPT, what is your dreaded complication if you do a bilateral neck dissection?
Carotid blowout or hemorrhage?
Carotid blowout? No, that is for if you do a unilateral.
That's what IJV for IJV book.
Please, student, whether it's UG or PG, please take 10 seconds. Manoharan Sir knows. He has been my PG's examiner on both sides. Always take 10 seconds, nothing happens. I take 10 seconds to answer.
Flap necrosis, sir?
No.
Hemorrhage? Why?
You're going to tie both the guys, right?
Yeah. Oh, cerebral edema.
Just think for 10 seconds. ICP goes up, yeah, cerebral edema goes up, yeah. That's
HCT, raised neural
Yeah.
Raised intracranial.
too much for you just because we were going, because your case is bilateral, I just sort of mentioned, but otherwise it's good. But this chief complaint of the patient, swelling. But everything in Socrates, site, onset, character, the extent of it, what everything should be one paragraph. What is the next complaint of the patient? For instance, hoarseness of voice. Not everything will be larynx. No. What if it is an infiltration to the nerves? So onset again is very important, guys. Just insidious onset in 6 months. No, you have to tell us when did it start and over a period of what time did it progress. Very important.
Okay.
Next spelling is at least your undergraduate, so 1.5 pages is only history taking.
Is what is
And
important.
checklist is, yeah, like in the UT Bibles is busy.
It's very common condition.
Yeah, head to toe is full checklist for examination for neck.
Important. Is what.
But otherwise it was good, yes. It is good, sir.
Just to go through the slides, Robin.
Yes.
Which are just run through the slide. Next, it's a very common thing. I'm not going to this slide. Very complex anatomy area. Already Robin has mentioned that. Now again, I'm highlighting lymph nodal mass is the commonest type of swelling in the neck. There's a point you have to always remember. All these things are the different causes. Next slide. So all these things I can see the tuberculosis here. Next secondary is fungating neck secondary lymphoma. You can see lymphoma lower part. So lymphoma, tuberculosis, secondaries. These are the three common conditions in the lymph node. You have to remember. Lymph node is the commonest mass. Next slide. So lymph node is the levels which already we have discussed. Inner wall ring, you have to remember adenoid, tubal tonsil, palatine tonsil, lingual tonsil. And you can see the lymph node. All these lymph nodes, every triangles, everything you have to remember. Already we have discussed it briefly. Next slide. So again, benign cystic hygroma, tortico, the bronchial cyst, bronchial fistula. See the collar stud abscess here. You can see, and Hodgkin lymphoma. You can see. Secondary, the look is different. See the look is different. It's one of the laryngosal patient which we have operated actually only X-ray is this actually. Next slide. So history already I have told why all the things laryngosal we have discussed the trumpet blowers and this is again typical swelling actually bilateral swelling here. So all these things are discussed in it because it's a typical neck second is in the neck of exactly skin is involved. Next slide. Next, so chief complaint neck duration pain. Is related to oral lesion. This already we have discussed in the orderly fashion why it is so. All those things. Next slide. So this is the chart like swelling, pain, other limb security, loss of function, fever, salivation. If we think of primary, related to the primary family tree, personal history, alcohol, smoking, palm chewing, all the things are important. If there is ulceration, the swelling. These are the things. Positive radiotherapy, earlier surgery. Already you have mentioned. We have discussed that. Next slide. So swelling again acute. Malignancy, tuberculosis, congenital swelling in other part of the body. Like already Robin told, axilla, guai, and abdomen. In the orderly fashion, levels already we have discussed that. Next slide. So 7 rules in the neck, 7 days inflammation, 7 months neoplasm, 7-year congenital defect. The usual standard rules we usually go through that. You have to remember. Next slide. So other history, pain, fever, discharge if there's a sinus. Relevant is cough, fever, hoarseness, dysphagia, ear pain, abdominal pain, dyspnea, other swellings. Person is smoking, alcohol, diet, reduce weight, radiotherapy. Next slide. Hoarseness already we have discussed. Thyroid, carcinoma, dysphagia, hemoptysis, pussy through the tongue, cough, dyspnea, bronchogenic ulcer, ear pain, deafness, nasal bleeding. This is some already Muthukumar sir discussed actually. Nasal bleeding and other things you will always ask specifically. Next slide. So this is the orderly you have to look for in these patients when there is a neck swelling, other drainage area, systemic examination. Next slide. Swelling, infection, swelling, again same thing, orderly, already Robin has told. Movement of the swelling, pulsation, impulse on coughing, we discussed, were not common, laryngoscopy can happen. Pressure effects, dilated vein, paralysis, deformity, wasting, all those things, edema. Next slide. This you can see the thyroid, go back. This is important, sternocleidomastoid muscle, see the muscles here, this the levels is very important. You have to remember this picture for examining the neck. Next slide. So both sides should be inspected. Swelling, commonest presentation, location, everything, every swelling is typical. So you can see how to examine orderly fashion. Already we have discussed. Next slide. Next. So again, I am not going to discuss this one. These things are there. Midline swelling, carotid, benign swelling, dermoid cyst, ranula, cystic acrobranchial cyst, which area, all the things I am not discussing, but please read it out. Next slide. Site is important. Extent, number, shape, all those things again we are discussing briefly. Which side is come in the bony point always, sternum, clavicle or mandible. And muscle, important thing is the sternocleidomastoid muscle. Next slide. And these are the things you can see, cystic hygroma, inflammatory swelling, tuberculosis nodules, you can see that. Bilateral swelling, lymphoma, extent actually. Thyroid cyst, you can see, suboid bursa. All these conditions, see how exactly it looks like. Next slide. So surface, nodular in secondary, matted in tuberculosis, smooth in bronchial cyst. And we have discussed that. Well-defined, regular. We have got a confusion about edge margin, what amount seen in the swelling. We have to mention well-defined and regular, well-defined and irregular or ill-defined. These are the conditions where it becomes like that. Next slide. So all these things, well, you can see that collars are very typical collars that have this space of dermoid cyst in the midline, bronchial cyst here, Hodgkin lymphoma in the young boy. And second is with the nodules and ulceration here. Next slide. So mobility of this mobility on inspection you have to look for skin over the swelling. We already discussed dilated veins are discussed as stretching of the platysma sign. That's what is seen in this one. That's what you wanted to express. Platysma sign is seen in this patient. Stretching of the platysma by infiltration. Next slide. That's called platysma sign. See that here, platysma sign. You can see that actually platysma sign here. You can see the platysma sign. Ulceration, these are multiple nodules. See the tuberculosis, sinus and abs, collars and abscess here. Stages of the tuberculosis lymph node is what Robin has asked. Next slide. So visible veins in the neck, all these are the reasons. I am not going to discuss that. Next slide. Visible pulsation, expansile impulsion we have seen in laryngoscopy. We have discussed that. Muscle wasting, the trapezius, spinal accessory, terminal muscles, hypoglossal nerve, torticollis in the children, not in this patient. Next slide. Nice. See the laryngoscopy blow actually. Valsalva maneuver. See the wasting of the trapezius here in the spinal accessory nerve is involved. You can see the wasting of the trapezius muscle. Shrugging will be absent here. See the dilated veins. See the typical dilated veins because of the large swelling. You can see the fungation here. You can see the fistula and here. You can see the expansile carotid pulsation. How to look for like this with the expansile outer deviation of your both fingers. Next slide. So pulsal sinus, thyroid fistula. I am not going to discuss the tubercular sinus. All this here. You can see the photo of the tubercular sinus. Typical look. Sinus does not have flu. Remember. Next slide. Next slide. This is go back. This is the chart palpation. I'm not going to detail. These are the things you have to mention. Sympathetic chain, hypoglossal nerve, spinal accessory, oral cavity examination, nasal cavity, ear, scalp. Already Robin has clearly mentioned. He has shown actually systematically different nodes, systemic examination. Next slide. Position, and how to examine this one. Always English with a mustard muscle. This is exactly we examine. Method of exam is important. We may have to demonstrate in the clinical examination. Next slide. Next, this is different things. This is important. This is the lymphoma patient, lymphoma. All this lymphoma exactly looks like typical bull neck like. Next slide. So temperature, tenderness, surface is important. Smooth surface, nodular surface, irregular surface, matted surface. Next slide. Consider soft, firm, hard, variable. That's what sir told. If it's variable, you have to mention variable. Don't tell soft to firm to hard. That is wrong. Induration you have to mention if there is an ulceration in the carcinoma. Next slide. So all this in temperature, tenderness, smooth surface, matted, see the matted, typical matted, stony hard, India rubber in tuberculosis, nodular surface, all of that how it looks like. Next slide. So plane of the swelling is the most important thing. Contact the thyroid muscle, then check the mobility. Skin pinching, already I have told skin is free or not. Next, the mobility in the two direction, always check in two direction to say it is freely mobile or not. Next slide. So mobility, I already told two direction. What are the reasons why adherent to the thermostatic prevertebral muscles, paravertebral muscles, whether it's fixed or not. If it is not mobile, fixed, it is the paravertebral muscles are involved. Next slide. So these are the things again, skin pinching, how to examine, contraction of thyroid muscle. These are the things just I'm showing it, pinching, skin pinching. Next slide. So again muscle contraction, mobility, different levels of the lymph nodes, and you can see that cervical rib also you can see here. Next slide. So bony swelling or immobile, that's what you have to remember in the especially cervical rib. Fluctuation, if it is fluctuant only check the transformation. Soft swelling only check the transformation. Probably Bayes test of fluctuation you should remember in a small swelling. Next slide, next slide. So transformation, if it is cystic, we check the transformation. See that? Brilliantly, you should have transformation scope actually. These are the things which can cause pulsation. Again, check the expansion transformated pulsation, how to do that. This is also important, especially carotid pulsation, carotid artery aneurysms or vascular neoplasms. Next slide. So compressibility, already we have discussed. It comes back to the original side. Vascular malformation, hemangioma and lymphangiomas are compressible, not every structure. So use your discretion when you say it is compressible, because when you say compressible, this specific, it is very, very specific. Again, expansion lymph crepitus, laryngeal, surgical emphysema, you can see the crepitations in a acute condition actually. Next slide. So neck lymph nodes are better examined from behind. One side is examined first, then later on the other side. All these levels you have to check and mention. This is what Keshav has highlighted. You have to always mention. This is the memoriam prone catering levels. Borders, boundaries you should know actually. Neck, and you will flex the neck towards the same side and check. This is how exactly it's shown in the diagram. Next slide. So this is how exactly look for different level 1, 2, 3, 4, 5, 6. It is the virtuous node of exact between the two external muscle and examination of the bidigital palpation of the for submandibular salivary gland to differentiate submandibular salivary submandibular lymph node and salivary gland. Salivary gland is bidigital palpable, lymph node is not bidigital palpable. So that is what you have to do in many situations when it's needed. Next slide. Next, so these are the different conditions, different levels of lymph nodes of enlargement of exactly 1, 2, 3, 4, 5. Next slide. So final accessory now, shrinking of the shoulder, deviation of the tongue. You can see the Horner's syndrome here. So how exactly this looks like that we just wasting. These are the things. This is the typical picture of these things very clearly. Next slide. So vessel involvement. Next. Spinal accessory, hyperpersonal Horner's syndrome, tracheal examination you are told, carotid pulsation, and laryngeal crepitus you have to check always. If it is absent in the laryngeal malignancy. Remember, normally it is present. This is the point which you have to remember. Normally laryngeal crepitus is present. Don't get confused. Next slide. If it is absent, it's called Boca's sign. Again, oral cavity should be examined on the posterior. You should use the tongue depressor when you examine the oral cavity, and tongue should be inside when you palpate the tongue, not outside. Next slide. So this is the different ways of examining the neck and oral cavity. So drainage area, all drainage area should be examined, level 1 to 4. Left suprachiasmal lymph node, pharyngeal sinus, Next, back, go back. One more here. So you can see the parallel sinus, ear examination, nasal cavity examination, thyroid examination, parotid examination. This is what Robin has highlighted. All these things should be examined properly to look for the primary. Next, palpation, other drainage area, percussion, remember, laryngeal, sternum tenderness, dullness over the sternum means mediasternal mass, auscultation for bruit. Is that what bruit is not in the palpation, bruit is in the auscultation, Abhay. Okay, so it's always in the auscultation, not in the palpation. Don't get confused. Next slide. So next slide. Slide has repeat actually. Again, next slide. Next slide. Next. Okay, other examples for generalized lymphadenopathy, inner void ring, other internal nodes. That's what Robin has told. What are things to look for? Isolated nodes, epitrochlear lymph nodes, paraortic, popliteal lymph nodes. So finally, clinical diagnosis. Next. So this is how exactly you have to give the diagnosis. Primary end staging you have to give. Which side you have to give. Then evaluation, treatment strategy. So rule of 10, back. Next, rule of 80% non-thyroid neck muscle, neoplastic neck muscle, males, neck muscles are malignant, muscles are metastatic, all rule of 80 you have to remember. Rule of 7, rule of 80, remember this one. Next slide. So all these things are the differential, the midline and lateral swelling. So these are all the things are the midline swellings which you have to remember. This is totally lateral swelling, remember. So these things will not come into the picture. Next slide. So all these things are the midline swelling. Look at this, how exactly it looks like. Peritoneal cyst, suprarenal dermoid, midline dermoid, thyroid isthmus, submental lymph node, sublingual dermoid, Ludwig's angina. All these are the midline one. Next slide. So this is the lateral swelling, submandibular, carotid triangle, posterior triangle. Here lymph node mass. All these things. Lateral lobe thyroid swelling, baby. Neural tumors, anomastide, bronchogenic causes are different entity. Remember. This is one of the differential for occult primary. Okay, submental salivary bronchogenic, not bronchogenic. Remember, CHIO is there, and punging renal. All those things are the differential for actual lateral swelling. So midline, lateral. That's why it's classified. Next slide. So again, acute, pulsatile, others, chronic cystic swelling, solid swelling. So that's exactly so that you will have the pathological identification of the swelling as such. If you are able to differentiate, identify these things, acute, pulsatile, others, so the conditions will come into the picture accordingly if it is so. So this is the, again, this slide will give a clear idea to give a final diagnosis clinically. Next slide. So causes of neck swelling, infectious, I'm not detailing it, neoplastic, immunological, drug-induced, others. Cystic, solid, vascular, sarcoidosis, hyperthyroidism, and so on. Benign, malignant, it's another classification. So these are exactly classified etiologically. Infectious, neoplastic, benign, malignant, immunological. These are the etiological classification of the neck swelling. Next slide. Next. So in this, the investigation already we have discussed. For lymphoma, remember biopsy, open biopsy is the investigation. Where for secondaries it is FNAC, not open biopsy unless it is fungating and ulcerating. So discharge study, AFB, maybe gene expert if you are suspecting tuberculosis, triple pan endoscopy, ESR, tumor markers, CT head and neck, PET CT if it's required, and so on. Next slide. So remember, examine both sides of the neck, contract sternocleidomastoid muscle, check carotid trachea, examine oral cavity, examine pharyngeal spine always. We are not mentioned that. Axial abdomen area, inguinal, epitrochlear, popliteal nodes. Look for primary if suspected, secondary. Respiratory system spine examination. Management concept you have to always remember, like R&D, MND. You know, presently terminology has changed. It is not no more called as MRND. It is called as MND. Modified neck dissection. Modified R is not there. You can use it. You can tell no problem. But newer AGC terminology has come as MND, not MRND. Changed it. MRND changed as MND. R they have removed it. And so these are the things you have to remember. Next slide. So my website, or if you subscribe, I request and share with others. Regular daily MCQs I am sending. You can try to answer that. You can please go through that. I request everybody to subscribe and viewers and join the regular live sessions and you get to know yourself to learn surgery. And my 8th edition book has come, new edition with the additional MCQ supportive booklet is there with that. So this is the QR code for the subscription. Again, I thank you for Isha and Abhay. They presented well. Of course, difficult case.
Pleasure is all ours, sir. Thanks a lot for giving us this opportunity.
With a lot of commitment, you have joined. Robin, I was missing you last session. You were there with me. Very nice of you. Keshav, we're always with you, sir. I thank you very much for joining. The 2 days back, day first day, he said he happily told he'll join because last time he was busy with some other work. So thank you, sir, again for joining and be with us in the website. Keshav, Muthukumar, sir, Robin, and Manoharan, sir. We'll implement some more things, whatever Robin has told. He has got some other plans. Maybe we'll be able to implement these things due course of time. Again, thank you, everybody, sir. Thank you, sir. Good night again. Again, thank you, Isha and Abhay. They presented very well. Thank you, viewers. Maybe it will be very useful to everybody because next swelling is Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you.
Thank you, everybody.
Yes, sir. Thank you.
Keshav, thank you, Keshav. Thank you.
Thanks, sir.
Yes, sir. Thank you.
Good night.
Thank you very much, sir.
Thank you, sir.
Thank you. Good night, sir. Good night.
Thank you, sir. Good night, sir.
Good night, sir. Good night, sir.
Good night.
Good night, Robin. Good night, sir. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Keshav, thank you. Keshav, thank you. Thank you, Abhay. Thank you, Isha. Thank you.
Thank you, sir.